Hi, I'm Joanne Conroy, President and CEO of Dartmouth Health, and thank you for joining us for our Connect with the CEO. I'm pleased to be joined today on WebEx by Dr. Brandon Wilson, who's Senior Director of the Center for Community Engagement in Health Innovation at Community Catalyst. Brandon joins me from Washington, D.C. to discuss health equity and health systems innovation and how political determinants of health impact various populations that receive health care in our region and our nation. Welcome, Brandon.
Thank you, Joanne.
Now, everybody likes to get to know our speakers before we really jump into the meat of the matter. And I know you live in DC and you're really a kind of a equity activist and your work affects so many people. So talk to us a little bit about how you ended up in the role you have now.
Sure. Well, it's been a journey, I would say. I grew up in rural Louisiana in a place that's known as Cancer Alley. So health disparities and inequities have been something that I've lived with for most of my life or have encountered in some form or fashion. After college, my first job was doing HIV and AIDS work, who were trying to bring folks into the continuum of care who were lost to care. And back then we were doing health equity and addressing social determinants and political determinants before we even had language for this. I then went to do case management, where it was screening for and navigating and connecting folks to care around addressing barriers to care. I did a brief stint in pharma and brand marketing, and then went to a national advocacy organization, National Association of People with AIDS. From there, I wanted to get into research, so I went to NIH and did HIV vaccine research, as well as SARS, Ebola, a few other things. I actually worked on Dr. Fauci's team then. And I found that research in clinical sense, you almost have to have long-term vision for that. And I wanted something that gave it at least a little bit more intermediate level returns. And after ACA passed, I went to CMS Innovation Center to take up domestic policy work, and then CMS Office of Minority Health, to implement on some health equity priorities for the administration. And now I find myself, I'm here back on the advocacy side with Community Catalyst, the Center for Consumer and Community Engagement now in health innovation. And I teach at UNC Chapel Hill in the Gillings School of Global Health.
Wow, you've had a fabulous career, Brandon. A couple questions about Community Catalyst. How big is the area that they serve? Do they really reach nationally in order to establish kind of advocacy policy agenda? Or do you find that your focus is actually more regional?
Yeah, I say it's both. We have national footprint. We have worked really hard for legislation on the federal side, things such as passage of ACA, that's a hallmark win for us. But even most recent, things like fixing the family glitch. Of course, we were really trying to push for funding for like home and community-based services and Build Back Better. But we've also worked very closely with partners in states and community coalitions so that we are getting that regional and state level footprint as well.
So you've spent a lot of time as kind of an equity activist. And what do you think about the environment now? I mean, people are they seem to be listening and embracing the fact that diversity and equity is really a sustainable path forward for this country and the health of the citizens of the country. But you're inside the Beltway, and do you feel that change as well?
I do, and I really give hats off to the Biden administration and really coming in and I think almost like just about day one, like really signing almost a dozen or so health equity related EOs, like one particularly EO 1395, which really commissioned all of government to make sure that there was an equity focus. And I think we are now beginning to see things such as the return on investment in taking up equity work. So we know that it works. It's not, but even if you were a person who would not move from it from a morality perspective or from an equity focused period, there is the business case to be made that it's just makes good sense, that it's actually impactful on your bottom line, and it increased health outcomes and status of people and communities that we all serve.
Now, the last.
I'm sorry. So if I can add to that just a little bit. So I think there is momentum, certainly. I think there is just a little bit room, of course, for us to get on the same page, even around like how we even define equity. But I would warn us that there is no one size fit all approach. There are multiple approaches. So I think something that holds us back sometimes is feeling that we have to have all the right answers to make any movement whatsoever.
And the last time we met, we were speaking at Dartmouth Health's Political Determinants of Health Symposium. And I think that was the first time that equity and health equity actually had a major platform in front of people that make decisions in the state of New Hampshire. And we talked a lot about the political determinants of health, and for a lot of people, they may not exactly know what that means. Do you want to talk a little bit about that and how we all believe it affects health outcomes and access?
Yes. So Daniel Dawes from the Satcher Institute of Morehouse School of Medicine is the individual who actually coined the term. And he put it this way, that the political determinants of health involve the systematic process of structuring relationships and distributing resources, administering power, and operating in simultaneous and mutual ways that reinforce one another so that it shapes opportunities for equity. I think that's just really wonky or fancy language of saying that political determinants of health, that they really create the social drivers, whether that's poor environmental conditions, inadequate transportation, access to health coverage and healthcare delivery, or unsafe neighborhoods, that all these things really affect other dynamics of health. And when we understand some of these determinants, the origins and how they impact equitable, I would say, distributions of opportunity as well as resources, I think that allows us to really be better equipped to develop as well as implement actionable solutions. And we can go back to Mr. Dawes for a second. I think he adequately stated before that if social determinants of health are the social factors that impact our health, then political determinants are the policy choices that led the social determinants in the first place. So if social determinants are the safe and affordable and quality housing, then political determinants are the conditions that cause that in the first place, such as codification of residential segregation and hyper-segregation, redlining and gentrification. There's a wonderful researcher in Baltimore, Dr. Lawrence Brown, and he did research in Baltimore and demonstrates how Baltimore is the first city in the U.S. that actually passed a residential racial zoning law in 1910. And he shows that public health data was actually used to justify the residential segregation. Health officials quarantined Black people in neighborhoods during TB and cholera, yellow fever, and outbreaks. And so the irony of that really is that the same communities that were hyper-segregated based on data from public health itself that have been disproportionately devastated by COVID-19 pandemic. I think we have to make space to hold some of that reckoning.
Yeah, there has been a tremendous amount of attention on decisions just as simple as where highways go, where bus lines go, where trains go, where we place schools. And you're right, some decision that's made by a legislative body actually shapes the social determinants of health and access to care and access to affordable transportation for many citizens that make it possible for them to get a better job or get a better education. And I think every single week in one of our major newspapers, there is another study that's educating us about the consequences of some of the decisions that we've made. There's another term, and you said, you've been working in equity before there really was a language around it. We talk a lot about health equity. So not just the social determinants of health, but then if you get a little bit narrow around the care delivery system and equity around that, how would you define that?
Yeah, I think one, I don't know that as a field that we've really come up with a uniform definition. Of course, I've seen different definitions from CDC and CMS, or World Health Organization, have their own definition. But the one that I think I find the most affinity with is one that's a progressive definition. I think that's out by Robert Wood Johnson Foundation. And they state that health equity for them means that it's that every person or community has a fair and just opportunity to be as healthy as possible. I think, but they go just a little bit further and really almost begs us to really take responsibility for it. And they state that it requires removal of obstacles to health, such as poverty and discrimination, and their consequences, such as powerlessness and lack of access to good jobs with fair pay, quality education and housing and safe environments. Like, it really requires addressing back to those political determinants of health. They put together a framework similar to one that CMS Office of Minority Health put out. OMH called it Disparities Impact Statements. And it's just a real quick and easy way to really measure or determine if we're making meaningful progress on advancing health equity. And to those in healthcare delivery, it uses a PDSA, or a continuous quality improvement methodology. Real quick, one is identifying if there are any important health disparities. Two, changing and implementing policies, laws, and systems and practices to reduce inequities. Three, evaluating and monitoring any efforts using short and long-term measures. I would really ask us to not get caught up on measures if we can. And then four, to reassess the strategies in light of processes and outcomes and planning the next steps.
Yeah, I think we're finally kind of doing the research and gathering the data that informs us. It's interesting, Canada has been doing this probably a lot longer than we have. And I remember reading a study that they connected people's health to their ownership of a car, at least in areas of Canada. If you didn't own a car, then you didn't have access to all the things that gave you a reasonable quality of living. And it's fascinating when you start looking at that data, you can actually connect the dots with great researchers. Now, Community Catalyst also invests in innovation. So talk a little bit about the ways that you've seen health systems innovate and innovate successfully in order to improve the delivery of care to patients.
Yeah, so I think, John, one way that as a whole that the healthcare delivery system is innovating is in addressing these non-medical drivers of health. I think we know that medical care is now estimated to account for only 10 to 20% of at least the modifiable contributors to healthy outcomes for people. And the other 80 to 90% is those things that we call social determinants, those health-related behaviors and socioeconomic factors, environment. And we're now, as I said earlier, we're now beginning to see ROI there. For example, Anthem's Care More Health. They partner with Lyft in several states and to provide transportation benefits to Medicare Advantage recipients. And you know what? They're now seeing an average of 39% cost reductions and about 45% lower wait times. AmeriHealth, they started a Food is Medicine initiative, and they partner with local community-based organizations as a way to address food insecurity. And they're now seeing 30% reduction in inpatient admissions and about 10% decrease in ED visits. On the workforce side, I think we all know now that we're really struggling with workforce shortages. And while we're trying to simultaneously provide person-centered care, Virginia is one of a few states, I think it's about 4 now, who now use a state plan amendment to promote racial and equity and maternal health outcomes. And they're doing so by allowing Medicaid coverage of doula services. And I would say healthcare companies are now using things such as drones for COVID, or during COVID they did, to deliver medication supplies to rural areas, or cloud-based CPAP monitoring and telehealth and telemedicine. And you and I were actually just discussing about wearable technologies such as Fitbits and how they integrate with our phones. So I think we're actually doing a lot in the innovation space. That's great. I think where we can go a bit further now is when we come out with these blockbuster technologies. The next stage of innovating is making sure that we innovate in processes to ensure that all these innovations are distributed equitably to all communities so that we can all take advantage of them.
Yeah, that's a really great point. It's interesting at Dartmouth College, they're doing a lot of work on how people interact with mobile technology, their cell phones. And they're finding so many interesting insights in terms of age, your ethnic background, how your families operate in the use of a technology that I think a lot of us take for granted, but how it actually can be very powerful and how it can tell us a lot about the person that's actually using that technology. So the amount of understanding and certainly the innovation that comes from that is significant. Have you ever seen an innovation you think that you could really push to get scale in, because a lot of these sound like they're in communities or in states. Do you imagine anything that we could actually expand much more broadly across the country?
Yes, I think that's a pretty good question. I think one, honestly, it is the wearable technologies. Not my caveat to that is I think as we're building more innovations and technology advancements, I think we can do a better job in ensuring that they are patient-centered and community-driven and actually meets the needs of people and their lived experiences from the outset in the forefront. That said, I think wearable technologies, to your point, gives us so much rich data that can really help understand behaviors of where we know people live and work and play and worship that can really impact their health status and health outcomes. I think the problem is that we're not seeing equitable coverage of that as a resource. So scaling that, I think what CMS providing authority to states and Medicaid to cover such a device for all of Medicaid recipients. I think that's one way to easily scale. I think back to my point earlier, I was listening to a podcast last week, and they're making a point how we've done a really good job with blockbuster innovations But the next step, again, is designing the infrastructure, the processes, so that we can scale it, so that we can get it to all communities. I think we think of innovation usually in terms of invention or coming up with a new product or new idea. But I think it's just as innovative to create the mechanisms, to your point, by which we can scale.
Yeah. So I want to remind our viewers that if you have a question, you can enter it into the chat function on the video and we can answer your question live. And we have a few of them. So these are from our audience, Brandon. So there's a question about person-centered and patient-centered care. Where do we most commonly see disparities in patient or person-centered care?
Yeah, that's a good question. If I can level set for 1 second. I think person-centered care really does take into account, if I can define it, the aims of the individual, on their preferences, needs, and values. And I really like to highlight preferences because I think often we think of needs only. And I think people really do deserve to have a healthcare delivery system that delivers the type of care that they want, that they prefer, and it values their whole being and doesn't narrowly focus on their illness or symptoms. Here at Community Catalyst, in our Center for Community Engagement and Health Innovation, we partner really closely with Leading Age LTSS Center at the University of Massachusetts at Boston. And we've been doing a lot of research and analysis on person-centered care and disparities that exist. Most recently, we looked at the health and retirement study, 3 waves, years 2014, 16, and 18. And we specifically looked at the question, when thinking about your experiences with the healthcare system over the last year, how often were those preferences taken into consideration? And this question really centers our analysis on, or focuses on probably the most fundamental component of person-centeredness, which is the ability of our healthcare system to consider our preferences regarding how we want to experience care. Our results, while not surprising, I think are still astonishing and certainly concerning. Research shows that when care preferences are considered, outcomes improve, but we're finding that that's not happening enough, and that there are some real stark racial and ethnic differences. Black and Hispanic older adults are more likely to report never having their health preferences considered versus white adults. 24% of Hispanic adults report never having theirs considered, compared to 17% for Black and 7% for white adults, respectively. Those who report their clinicians never account for their preferences are twice as likely to have income below the federal poverty level. And higher numbers of persons on Medicaid report that they have never had their preferences considered. And Joanne, person-centered care, I would stress, it's really imperative to a high-quality healthcare delivery system. It's not a luxury or a nicety. It's really essential. People who experience person-centered care, we know that they have higher satisfaction with their care. They have better control of chronic conditions. They receive more preventative care. They have lower projected healthcare costs. And so, to me, increasing quality, increasing outcomes, reducing costs, it almost sounds awfully close to like health innovation.
So as a follow-up question, when we look at the trends and disparities and how patients receive their care and having their preferences both acknowledged and attended to, does it depend on the provider or the clinic or where they get their care? Has that emerged in your research?
Yeah, so we are seeing that there are patient-level factors that are modifiable, such as education, We're also seeing provider level factors that's modifiable usually by education as well, or cultural competency training, providing language equity, making sure that we address things such as health literacy. And then there are modifiable health system barriers as well, things such as financial barriers to care, such as affordability and medical debt. These are real barriers that impact whether or not a person is able to access or even maintain their level of care with their providers.
Have you identified differences in site versus a primary care office versus an emergency room versus a specialist office, or has the research not gotten that granular?
It may have. It's not something that I have seen, but I can tell you we are seeing some disparities in usual source of care, particularly around primary care. And I've seen that for everyone, actually. But of course, we are seeing some stark racial and ethnic disparities. And we think that some of that, of course, is likely contributing to ongoing health disparities and made worse, of course, by COVID-19 pandemic. Hispanic individuals have higher rates of no usual source of care. Black individuals as well. There's about a 10% decline in that for those with dual coverage of Medicaid and Medicare. Younger persons, about 40% between ages 18 and 34, have no usual source of care. And there are a few reasons that I think the research is showing. I think one, a rise in alternative sources of primary care services such as retail, emergence of retail clinics and urgent care and digital health. I think all those things may be substitutions for primary care providers. I think a maldistribution of primary care. Of course, we know there's shortages in the workforce, whether that's in urban areas as well as rural communities alike. And probably also, lastly, a rapid rise in employers who are offering high deductible health plans, which can also pose a real financial barrier to people getting the primary care sources that they need.
Yeah. And New Hampshire has one of the highest rates of high deductible healthcare plans in the country. And there's a tremendous amount of literacy in understanding how to use your benefit that's actually required to navigate that. Just two final questions. The first is about sexual orientation and gender inclusion data. Why is that important in today's healthcare landscape?
Yeah, I think back to one person-centered care, individuals who've been able to bring their whole self to their healthcare provider, I think allows us to improve in health status and health outcomes. And it's really almost very, very difficult to compartmentalize or disaggregate who we are as people and how we present. There was a study, I think it was an equality study maybe a few years ago, led by a few researchers from Harvard and maybe Hopkins, as well as Fenway Center in Boston. And they looked at that very question around SOGI data and preferences around it. And there was some discordance between patients and providers. Most patients, no matter how they identified with orientation, all felt that it was a value add to have that question asked of them. But most providers did not feel comfortable asking the question, but not for some sinister or negative reason. Most actually thought that asking the question, there would be opportunity for discrimination or bias to creep in. So I think the strategy, to addressing that, I think is probably addressing things such as implicit bias and having more training for providers on how to ask these questions and culturally competent manners. But I think it certainly leads to healthcare experience, also outcomes. There are certain modes of treatment recommendations for preventative as well as care, such as PrEP or pre-exposure chemoprophylaxis, although that's now expanded beyond sexual orientation, but I think it's one preventative strategy that you may want to offer to sexually active men who have sex with other men, or same-gender loving men, or gay men, depending on how you identify.
Yeah. The final question is, people don't think of Northern New England or New Hampshire as particularly diverse, but you've been up here, and we probably have diverse populations that aren't as visible as the color of your skin. How should people think about diversity in a state like New Hampshire?
Yes, I think diversity should probably be, I think it's probably easiest to think about it when we think about our own selves. And I think the concept of intersectionality, that we're not just a Black or white person. We're also our gender, our sex at birth. We're also, whether we live in rural, urban communities that impact us, our faith or lack thereof, our families and our cultures. Those are those traditions and habits and methods of existing and being that really shape and impact and influence our behavior. So all of those things show up at once, and really makes, I think, lives colorful and diverse. So I think, to your point, yes, it goes far beyond race and ethnicity. And I think Dartmouth, I think Dartmouth Health, correct me if I'm wrong, the academic medical center, is the most rural, or certainly one of the most rural, in the United States. I think that you certainly wrestle with and struggle with the diversity in providing high quality care in rural communities.
Well, thank you, Brandon. This is really helpful, and I know all of our viewers will have enjoyed this session with you. I want to thank everybody for watching and the great questions, and for spending some of your afternoon with us. So thank you again, Brandon, and to our audience, see you next time.